Recently I was on call in our hospital over the weekend. It was a relatively typical weekend, but highlighted to me a few of the challenges faced by hospital specialists in New Zealand hospitals today. I should preface what I'm about to say by saying that I work in a DHB that is high performing compared with some others and prides itself on systems improvement. So this description is not a particular reflection on my DHB, but more a reflection on what's happening in New Zealand. Firstly, on the Saturday morning, the registrar on the ward with me was a relief registrar who had not worked in our service before. This is now a common scenario. The registrar had no patient handover for the weekend. I was therefore the person providing continuity of patient handover, patient information and patient care. This always used to be the responsibility of the resident medical staff and training, and is being progressively shifted more towards the specialists. We now have many more RMOs in our hospital than ever before, but it's more difficult to find resident doctors to provide cover, and we work with our own trainees less than ever before. Schedule 10 of the National Multiple Employers Collective Agreement, MECA, negotiated by RDA and the DHBs, but with the senior medical staff marginalised in that process, has markedly worsened the situation with frequent roster days off with resident doctors. In contrast, senior doctors frequently work 12 days in a row when on weekend call. Schedule 10 may have been a good thing for addressing fatigue issues in resident doctors. However, the consequences of reducing fatigue for resident doctors may be increasing fatigue for senior doctors. Secondly, although there were 5 mobile laptop computers on my ward for the ward round, they were not particularly new or fast. None were plugged in to keep charged, and so we tried all 5 before finally finding one that had enough charge. So rather than making our lives, just got to flick back a bit. There was a further delay of many minutes while the laptop booted up, and it therefore took about approximately 30 minutes before we could actually start to review patient information and start the round. We were then needing to use 3 different electronic devices to view patient results, medication chart, patient observations all at one time. So rather than making our lives easier overall, going paperless has so far been shown to increase doctors' workload significantly. Time spent on computer documentation is one of the strongest predictors of burnout. It's from a recent article from Edward Gawande. Thirdly, there were approximately 4 times as many patients to look after on the ward as compared to a weekend in 2000. So just looking at this slide, here's the patient numbers, 400 in 2000 up to close to 1800 this year. The SMO FTE rose from 4 to 9 over that time. So although patient numbers went up 4-fold, SMO FTE went up double, or only 2-fold. I suspect this is a similar sort of ratio across many of our specialties throughout New Zealand. Next, on the ward round, there was a delay in reporting a radiology test for a patient from the previous day, making a treatment decision more difficult. Our radiology service in Christchurch has been the envy of other services and other DHBs in the past, but test delays have now become common, and basically this is due to excessive workload for radiology staff and understaffing. Another patient was awaiting cardiology advice, and an echocardiogram that appeared awaiting for an echocardiogram after appearing to have a small cardiac event with an upper GI endoscopy 3 days earlier. However, there is a major shortage of cardiac echo technicians. This is not just in Canterbury, but more widespread. So the echo had been delayed until a cardiologist could do this himself. We were therefore unsure whether the patient's chest pain was related to the esophageal procedure or to a heart attack. Like radiology, our cardiology service has previously always had a very good reputation for rapid response and high quality. Our DHB has actually done exceedingly well in reducing hospital length of admission, but when significant short staffing causes delays in tests, then it's inevitable that lengths of stay will start to go up again. I could go on, but I'm sure you get the picture, and you all probably recognise many of these issues right across New Zealand. Increasingly inadequate DHB hospital funding is resulting in inability to recruit enough senior and medical doctors, fund high-quality modern IT equipment and medical record systems, or employ enough ISG staff to keep systems running smoothly. What this shows is just a sort of a graphic of the resources that we've been having improvements in over the last, I've got 8 years there, which funds workforce and buildings, and patient need, which is outstripping the resource that's being provided. And this unmet need is growing larger all the time. Okay, so furthermore, the 20 DHBs often have up to 20 different IT systems that don't integrate. This suggests a lack of good leadership at the highest levels. Whilst this is what specialists are dealing with on our wards, at the same time our workspace conditions are steadily eroding. Due to having outdated hospitals with lack of space, offices that were once used by individual doctors to work efficiently without distraction are being converted to be used by 2, 3 or 4 doctors, or doctors alongside nurses and administrators. In the new hospital rebuild, senior doctors are now asked to work in large open plan offices with colleagues, resident doctors, secretaries and administrators. We are told that this is the way forward and will encourage increased communication between staff for better outcomes. However, virtually every piece of research information assessing open plan offices concludes that this theory is mistaken. From almost any angle one cares to look at, open plan offices are damaging and not a good idea. This environment results in worse relationships between staff, worse communication, reduced privacy and patient confidentiality, reduced ability to concentrate, and importantly up to 30% reduced productivity. This productivity alone rapidly negates and exceeds any cost savings from reduced building costs by the use of open plan offices, making open plan the expensive option in the medium to long term. Recruitment and retention of staff would also be expected to be worse, leading to even greater costs. I like this guy in the corner. This device is actually called WearSpace, and they're seriously marketing this for open plan offices. I thought it was great. So, what happens to senior doctors when they're placed in an environment where there is too much work, reducing resident doctor support, increasing need to use electronic systems that take up more time than paper-based systems, and suboptimal workspaces with lost ability to work quietly and reflect? The answers are in ASMS surveys over the last 3 years. Half of us are fatigued to the point of burnout, 70% for younger female doctors. A third to half of us are subjected to or witness bullying on a weekly basis. And we work when we shouldn't work due to illness and the worsening, which further worsens the burnout. This slide is some of our data that you'll already have seen, but there's a very close relationship between level of workplace demand and the percentage reporting of bullying. Close relationship. And I guess the other thing is 1/4 of us are planning to leave the medical workforce in the next 5 years. And all of these things are worse for women doctors, with rates 10 to 20% worse in every situation. But perhaps most importantly, what happens to patient care in this environment? Not only is there a large unmet need, whereby many patients can't get seen because there are too few doctors, or wait for months or years for treatment they should be rightly having within days or weeks, but when they do get to see their doctor, there's a 50% chance that the doctor, due to burnout, will not be able to express compassion or empathy for their condition, or give the time and energy required. Patients understand this. They recognise that their patient is burned out when their doctor is burned out. Think about the number of times you've heard from a patient that they felt their doctor was not listening or providing empathy. So sadly, many New Zealand public seem to be resigned to this situation now, especially the elderly, beyond the point of being able to fight for their rights. At this point, it's worth recalling the 2013 presidential address of our past President, Hein Stander. Thanks, Hein. His focus was on compassion. He described that compassion drives what you want, describes or drives you what to, I'll start again. He describes that compassion drives you to do something about the other person's suffering or problem, to step in and help. This seems pretty important for good patient care. Lack of compassion is frequently mentioned as a factor in Health and Disability Commissioner complaint reports. Lack of compassion was a contributing factor in events at Mid Staffordshire. And yet, burnout will mean that 50% of us will not be able to provide compassion. Between around 2010 and 2017, we witnessed a steadily worsening mismatch between DHB funding and patient need. Each year being told by the Health Minister that we shouldn't complain because he was giving more and more money to the DHBs every year. This is not strictly untrue, but disguised the fact that less and less was being spent on health over this time as a percentage of GDP. So I'll just go over this graph a little bit because it needs some description. This is from data that Lyndon Keane has provided for me from our research department. What we've got here is the health services, the level of health service in 2009. And even in 2009, I think you'll recall that the health services weren't particularly flash even at that point. But since then, we've had this decreasing funding relative to patient need. So by the time we get to 2017, we're now $2 billion short per year compared with the same level of funding and care that we would have received in 2009. In 2017, with the Labor government, they did a little bit to correct this. They've basically stemmed the flow of blood leaking from the patient, but we're still a very long way from what we were in 2009. It's been encouraging that the new government is appearing to listen and can see that the precarious state of our health system has now reached. It's now a huge test for the government to respond appropriately and raise the priority of health of New Zealand citizens to at least a similar level of comparable countries. Actually, I'll just go back one there. Okay. Our member surveys and economic analyses show that we need approximately 20% more senior doctors than we have right now just to deal with current patient loads. This figure of 20% seems to be relatively consistent across the DHBs, with data coming from our clinical directors in each service. And in fact, you'll see in some DHBs it might be closer to 25%. Just last week, results of a national survey of gastroenterology services showed that we lag well behind similar comparator countries in specialist numbers at a time when we're expected to start providing bowel cancer screening colonoscopies on top of our current endoscopy workload. So what this shows is New Zealand here has 1.93 gastroenterologists per 100,000 population. Australia, our closest number, is at 3, substantially higher. USA 4.15, even Scotland and the UK significantly ahead. And these black areas are actually showing where there is no gastroenterology service whatsoever in New Zealand. Another consistent finding from our research, as hinted before, is that the negative effects on specialists from overwork and suboptimal working conditions are worse for our female colleagues in every case. Worse burnout, worse bullying, worse presenteeism. Almost 40% of our members are female, and the results we are seeing cannot be ignored. You'll see that ASMS is increasing its efforts and to gather data to address possible gender inequity. Addressing this will almost certainly result in gains for both females and males. Good medicine and good patient outcomes are very dependent on good teamwork. If a team member perceives that they're not being treated equitably to other members of the team, they will not want to contribute wholeheartedly. Everyone gains by addressing inequity. Discovering factors that improve work-life balance for female doctors will almost certainly result in gains for male doctors also. So what this slide shows is some early data analysis from our salary surveys across New Zealand, looking at SMO salaries. And what we're seeing here is that we've got salary steps on the x-axis, we've got female to male representation on the x-axis, on the y-axis, sorry. What we're seeing here is that in the lower steps in our salary step bands, there's an overrepresentation of female SMOs in these lower steps, as compared to the higher steps where there's underrepresentation. This shouldn't happen. This doesn't make sense. And I'm sure there's going to be a lot more come through when we look at our further ongoing research. And Charlie Chambers is going to be talking to us in some more detail about some of this later today. Okay, the issues I've described have been very well researched and analysed by our ASMS, our National Office team, and the challenges are clear. You will see from the annual report that the association is working hard on all fronts to improve the situation for senior doctors across New Zealand. From helping individuals with difficult workplace issues, working with DHBs and the Ministry to give SMOs a voice locally and nationally, gathering and analysing important research data to look for solutions to some of these issues, or expressing the viewpoint of members through our communications team. This all requires a lot of commitment from our ASMS team. I continue to find the dedication and professionalism of the ASMS team to be inspiring and humbling, and their services seem more important right now than ever. Regarding addressing inadequate doctor numbers, the best tool we have is job sizing, which usually commences from service sizing, and especially if this had become a regular exercise. Job sizing is an entitlement of the ASMS negotiated MECA, and ASMS has recently advocated for a staffing accord between government, ASMS and DHBs for senior doctors and dentists employed by DHBs, designed to recognise the precarious state of this critical workforce and committing to address by using the tools available, which includes more widespread use of service sizing and job sizing. Sadly, the DHB chief executives have responded verbally that they don't have a strong appetite for an accord. The Minister of Health has responded verbally positively. We trust that Dr Clark will commit to become part of the solution rather than being part of the problem, and require DHB to significantly improve their engagement with senior doctors on this issue. Larger than life. As you may know, ASMS is about to go through this major transition, which Julian has reminded us about. Our first and only Executive Director of almost 30 years will be moving on later next year. Ian Powell has always been the face of ASMS, and one could say that ASMS has been his life's work. He has overseen his organisation grow and develop hugely in ranges of services and numbers of staff from 2 to 18. We will be celebrating his leaving in a significant way closer to the time. However, Ian's moving on has given the executive much to think about. Furthermore, as Julian mentioned, half of the executive is new this time around. We've therefore taken this opportunity to assess our governance and financial processes with outside professional advice to be sure that ASMS remains strong and well organised into the future, and that the executive can add as much value to the association as possible. You will see that tomorrow we have a session using Poll Everywhere to get... Whoops, my computer has just died on me. Reminds me of that ad. Hang on, I'll fix this. Okay, so Poll Everywhere. So we're going to get active delegate feedback on ASMS direction and activity tomorrow. It's done it again. That's remarkable. Can you hand me... It's back on, but there's a piece of paper in there with the speech as well. It's in that folder. Okay. So we're doing this survey tomorrow to get active delegate feedback on ASMS direction and activity, and to help the executive and national office with decision making during the upcoming transition. So despite the challenges ASMS members face in New Zealand, there are also many opportunities to be taken, and ASMS will continue to make important differences in our work lives. Final slide. The biggest challenge lies with our government, however. To recognise the data and showing that health expenditure is an investment with a return, and to ensure that New Zealanders have the healthcare that they deserve by being cared for by adequately resourced health professionals who are not so burnt out that they can't provide compassion, and who have the time and energy to improve the efficiency of our health systems as well as doing their normal work. In summary, we need around 20% more hospital specialists in our DHBs urgently. Thank you, Julian.